Everyone. I think I'm audible, Dr. Dev, and visible too.
Yes, you are audible. Yes, you are audible and you are visible. Thank you, sir.
Okay. So at the outset, good evening, everyone, and I would thank everyone for joining in their busy schedule. And I would thank uh, Johnson for providing the opportunity, and I would also thank Dr. Dev for sharing these beautiful slides. It has been made by him. So with this in background, so today I will be presenting CLL. The initial part will be basically on the background of CLL. How do we diagnose? What is the prognosis? And what are the treatment options? And then I will be going into the management part, specifically addressing what is the data we have on Ibrutinib. So initially, I will present what is the CLL, what are the definition, clinical features, symptoms, prognostic markers, diagnosis, and then managing CLL with Ibrutinib trials, and then we will summarize. Quite a lengthy presentation. I will try to keep it crisp and understandable. So we know CLL is chronic lymphocytic leukemia. The moment it is chronic, it takes a long time for patients to become symptomatic. It is characterized by accumulation of small lymphocytes with minimal cytoplasm and a clumped nuclear chromatin. So the abnormal B cells appear morphologically mature but are immunologically incompetent. So raised lymphocyte counts in an elderly patient with an increased numbers of small lymphocytes with characteristic CLL appearance is when we think of CLL. Very importantly, because these abnormal cells keep multiplying, they start replacing and suppressing other cell lines. Therefore, you see anemia, you see neutropenia or other leukopenia, and platelets not only are less in number but also functionally incompetent. Therefore, you see bleeding, petechiae, ecchymosis, and so on. So, CLL is a heterogeneous disease, not only at the genetic level, but not only at the chromosomal translocation level. Even if you look into the IGVH mutation, so if a CLL cell is mutated, uh, uh, that means it is a memory B cell. So mutation is sort of good prognosis. The somatic hypermutation in the variable region of IGHV being there, and then the cell of origin is a memory B cell. Whereas unmutated is always unfavorable. So we always used to remember unmutated is unfavorable. So if there is no somatic hypermutation in the variable region of IGHV, then it's an unfavorable prognosis because the cell of origin is a normal or a naive B cell. So unmutated is unfavorable, and mutated is favorable. And this is a natural history of CLL. It's a heterogeneous disease. We have the big subset of patients who have indolent disease where they do not even become symptomatic for 10 years. They just live without being symptomatic. Whereas we have the other extreme where they develop rapid progression and they become symptomatic within 3 to 4 years, and they succumb within that time. So CLL is a heterogeneous disease. One subgroup where without any treatment they cross 10-year mark, whereas the other subgroup, with whatever best you do, they hardly cross 4-year mark. So it's a heterogeneous disease with different outcomes. And very importantly, in the small 5 to 10% subset of patients, there is a high grade transformation, what is called as Richter's transformation, with sort of a lethal sort of a transformation. And the moment transformation happens, the median survival is 10 months. This can be usually picked up by doing a PET CT where you see a lighted lymph node or an area with a high LDH levels, deterioration in performance status, fast developing hepatosplenomegaly. So this is when we suspect Richter's transformation and we treat these with just like any other high-grade lymphoma. So CLL is a heterogeneous disease. A big chunk of subset without even treatment they cross the 10-year mark, and other subset where they rapidly progress and they succumb to disease within 3 to 4 years. And Richter's transformation is a catch. We always have to watch in these CLL patients. And whenever it's there, we need to pick it up and treat like a high-grade lymphoma. So what are the key factors that determine the clinical course? So one is these factors are sort of interdependent. For example, if it is an elderly patient, they usually have a sort of an indolent disease and they present in the early stage and they have good cytogenetics. Whereas if it's a young patient, they present an advanced stage and they have poor cytogenetics and their survival is poor. And very important is the performance status of the patient, which we have to consider because majority of CLL patients are elderly. They have comorbidities, and we need to control those comorbidities before we venture onto CLL therapy. So these factors are interlinked. Uh, uh, Elderly age, asymptomatic, early stage disease, has good risk cytogenetics, respond well to treatment. Whereas the other subset, younger age, high risk cytogenetics, fast proliferating, advanced stage, have poor response to standard treatments. So CLL is currently incurable because we are able to give effective therapies and prolong the progression-free and overall survival, but somehow we are not able to cure this disease up to now. So the initial treatment may achieve a long response, but all patients eventually relapse and require further therapy. And very importantly, if you have a patient with asymptomatic CLL, there is no hurry to treat. So early treatment will not improve survival. So wait and watch is an appropriate approach in a patient who doesn't qualify for symptoms or the criteria for treatment. So treating right at the diagnosis is not the way to go. Wait and watch is a good option because intervening early doesn't improve overall survival. So this is the epidemiology of CLL. So in the West is one of the most common malignancies, B-cell malignancies. The median overall survival is around 7 years. As I said, it's a heterogeneous disease. Small subset surviving less, and the larger subset crossing 10-year mark. And the incidence varies considerably, males being affected more. The Caucasians are affected more than Asians, and 10% patients will have a family history of disease. So, if you look into the CLL in India, so CLL is the most common leukemia in the United States, 30%, whereas in our setting, it's just less than 5% of all leukemias, and lower incidence among Asians, and younger age of presentation, aggressive course, and shorter time to treatment. As I said you before, younger age, high risk cytogenetics, aggressive course, and shorter time to treatment. So these are the real world data from India. This was a prospective study of 400 odd patients. The median age of presentation is 61, less than what we saw in the Western population. And FISH was done in nearly 50% patients. And the treatment chosen upfront in those times was chlorambucil and bendamustine in around 30%. And with BR regimen, there was grade 3-4 neutropenia and infections in 50 and nearly 40%. So BR is a standard treatment, but associated with toxicities with grade 3 for neutropenia in nearly 50% patients. So CLL is primarily elderly disease. However, in our setting, we see younger CLLs in the Indian setting. The peak incidence is around 70 years. Only 10% of patients present at less than 55 years, and it is very rare, less than 40 years. So there is a tendency for older adults presenting with less advanced and less aggressive disease. So how do they present? So they present nearly 50% patients present with an asymptomatic increase in WBC counts. So the other symptoms include anemia, enlarged lymph nodes, B symptoms, prolonged or recurrent infections. So the key presenting features of CLL, you can see, so we could see that on one extreme, they are totally asymptomatic. They have just high absolute lymphocyte count or high WBCs. Whereas in the other extreme, as the CLL progresses, they tend to develop generalized lymphadenopathy, and then they start having marrow disease, where they start having low hemoglobin and then low platelets, and then further on they start developing B symptoms, and they may also have bulky spleen, bulky liver, bulky lymph nodes, and so on. So how do we diagnose CLL? So CLL diagnosis is quite simple. We have to, whenever we have a large elderly gentleman coming with high counts with generalized lymphadenopathy, hepatosplenomegaly, we look under the peripheral smear. We see the classical small, mature appearing B lymphocytes with a thin rim of cytoplasm with a dense nucleus and no discernible nucleoli. And the absolute lymphocyte count should be more than 5,000, and it should be persisting for at least 3 months. So there are a lot of patients who come with the lymphocyte count is there 5,000. What needs to be done? So it needs to be persistent at least for a period of 3 months. So the way to establish diagnosis is by flow cytometry, CD5 positive, CD19 positive, CD23 positive, CD20 dim. So these are the ways how we pick up and confirm the diagnosis of CLL. So these are the Rye staging. This is how we stage CLL. The Rye staging is quite commonly used than Binet. So if you look into the Rye staging, just an increase in lymphocytosis without lymphadenopathy is Rye stage 0, whereas stage 1 is there is lymphadenopathy. Stage 2 is hepatosplenomegaly, that is there is liver and spleen being palpable, and the stage 3 is anemia, and the stage 4 is thrombocytopenia. So usually the progression of CLL happens through these stages. So first there will be WBC high or absolute lymphocytosis, and then we have lymphadenopathy, and then we develop organomegaly, and then there is marrow disease causing cytopenias, uh, thrombocytopenia, and anemia. So what are the prognostic and predictive factors in CLL? Very important is age. Older age have a poor prognosis because they have associated comorbidities. Males have a shorter survival, and a high comorbidity burden also imparts poor survival. Very important is the lymphocyte doubling time. So if you look into the lymphocytes, CLL patients, when we see them for the first time, we usually follow them up after 2 or 3 months, and we see is there any doubling. So if there is doubling in a matter of 6 months, then we consider it as a fast lymphocyte doubling time. So patients with a shorter lymphocyte doubling time tend to have poorer outcomes. In many cases, a short lymphocyte doubling time is associated with a progressive disease. So when you saw a patient who has been indolent for quite long, followed him up for around 5 to 6 years, and suddenly the patient started developing rapid progression, the LDT increase or the time between the two, the intervals become shorter. There's doubling, then probably the patient would have acquired an additional cytogenic abnormality. So it is very important to do a cytogenic testing at each progression. So it is very clearly shown in this slide. So if you look into the types of cytogenetic abnormalities, deletion 13q is seen in approximately 40% patients, and it imparts good prognosis, and you can look into the median survival crossing 15 years. Then, so deletion 13q is a good subset. And then we have deletion 11q, which is seen in around 25% patients. So it's a strong predictor of poor response to therapy, and the median survival is approximately 6 years. And in deletion 17p, it is seen in newly diagnosed patients in around 10%, whereas if you look into the relapse refractory, it can go up to 50%. That means deletion 7p can also be acquired. It may not be there in the baseline, but at each progression, the chance of acquiring this ultra high risk deletion 17p mutation increases. Therefore, there is a need of testing this deletion 17p at each progression, because the whole treatment changes when the moment you get this deletion 17p. And also, as I said to you, IGVH mutation status, the moment it is IGVH unmutated, it becomes unfavorable, has a higher genetic instability, rapidly aggressive disease, short time to treatment, the lymphocyte doubling time is less than 12 months, abnormal cell morphology, and advanced stage. Whereas the mutated one, which arises from the memory B cells, have a sort of indolent disease, they have good response to treatment, they're slowly multiplying, the lymphocyte doubling time is more than a year. So this is the CLL IPI, again combining all the parameters and making a score. The International Prognostic Index, you can see age more than 65, you get one risk score. If it is Rye 1 to 4, then it becomes 1. So if you have any lymphadenopathy, it becomes 1. And then beta 2 microglobulin more than 3.5, which actually says about the disease burden. The score becomes, you can add 2. And then if the IGVH is unmutated, you get 2. And the moment it is deletion 17p or P53 mutation, then it becomes 4. So if there is 0 to 1 risk factor, then the risk is low and the 5-year survival is nearly 93%. And the moment 2 to 3, it's intermediate, 80% survival, 4 to 6, high risk, and the moment it is 7 to 10, then becomes ultra high risk or very high risk, and survival, 5-year survival is around 20%. So whenever a CLL patient comes to us, then we must always look into what is the CLL IPI score. So I was saying you that CLL in majority of patients presents with asymptomatic high absolute lymphocyte count. So we did not treat all these patients. We treat these patients only when they satisfy or they have these criteria being met. Otherwise, we don't treat. So the general approach is to wait and watch, and treatment is not recommended otherwise. So when do we treat? What are the indications for treating CLL? Number one, any B symptoms, unintentional weight loss, that is more than 10% in previous 6 months, significant fatigue, cannot even perform activities of daily living, and then fever more than 100.5 degree Fahrenheit for at least 2 weeks without any evidence of infection, night sweats for more than 1 month without evidence of infection. So we must always rule out infection. So when the patient has symptoms, it becomes an indication to treat. And then evidence of progressive marrow failure, either anemia with hemoglobin less than 10, platelets less than 1 lakh, then we treat. And then if there is massive splenomegaly, that is more than 6 centimeters, or there are massive nodes, more than 10 centimeter longest diameter, then also we go ahead and treat. And progressive lymphocytosis, increase in 50% over a 2-month period, or the lymphocyte doubling time less than 6 months, they become ideal candidates for treatment. And if there is treatment refractory autoimmune cytopenias, either thrombocytopenia or autoimmune hemolytic anemia, then it becomes important to pick them and treat. So these are the indications for treating CLL. So if you look into the cytogenetics and serum markers, so these are the markers we have. We usually do cytogenetics, we do beta 2, and we look into the IGVH, look into the age and the comorbidities. These are important factors before we venture on to treatment. So how do we treat CLL? So it's an extremely heterogeneous disease. As I said you before, treatment should only be initiated in a patient with symptomatic or active disease when it meets those criteria. So before we start treatment, we must make sure that any one of those criteria is met, and we must always do chromosomal mutation analysis, beta 2 microglobulin for the CLL IPI scoring, We must specifically address this deletion 17p, but whether it is there or not, and the IGVH mutation status also become important. So these criteria we already discussed. So, when we decide that we have to treat the patient, we must have the 17p deletion, whether it tested or not. We can do this even in the peripheral blood. We don't routinely do bone marrow in CLL patients. So, what are the treatment strategies we have for CLL? Wait and watch is the most common and the usual way we go ahead with. And we use FCR in patients who are young, less than 65 years, and in those subset of patients who do not have this 17p or TP53 mutation. And nowadays we are also focusing on this FCR only in the subset where there is IGVH mutation being present. IGVH unmutated, still we are not offering them FCR. And then bendamustine rituximab in patients who are not fit above 65 years, we do give, even though it is little well tolerated, but the cytopenias are profound and we may have to delay those subsequent cycles. As we saw, the incidence of grade 3-4 neutropenia is more than 50%, so not that well tolerated. And then we have other alkylating agents like chlorambucil, which we hardly use nowadays. And then we have monoclonal antibodies, especially rituximab, obinutuzumab, ofatumumab, which I'll be showing further. And we have novel agents like ibrutinib, we have acalabrutinib, then we have idelalisib, venetoclax, which I'll be showing further. So treatment of relapsed CLL is incurable. So we give some frontline therapy. The patient is having good response for some time. Again, the disease is going to come back. So what is the progression-free interval? Helps me to decide what subsequent therapy I have to give. If the progression-free interval is around 3 years, then I would not hesitate to re-challenge with the same drug. But if it is shorter, then I would be changing with novel agents, which I'll be discussing further. So these are the guidelines in NCCN and Esmo. You can see a lot of names. You can see ibrutinib, idelalisib plus rituximab, venetoclax plus or minus rituximab, chemoimmunotherapy of ofatumumab, obinutuzumab, rituximab plus lenalidomide, high-dose methylprednisolone plus rituximab, and so on. So if you have a p53 mutation, then the best way is a BTK, like ibrutinib or acalabrutinib, and we have venetoclax plus or minus rituximab, idelalisib plus rituximab, idelalisib monotherapy, high-dose methylprednisolone and rituximab, and so on. So I'll be discussing these combinations later. So ISMO recommends repetition of frontline therapy if you have more than 2 to 3 years of progression-free interval. So extended dosing of either LEN or ofatumumab maintenance therapy for patients who achieve CR or PR after relapse refractory scene. Recommendation extends to patients with or without p53 mutation. So allogenic bone marrow transplant for patients who fail to respond several lines is also there. So, but transplanting still is not easy because the relapse rates are higher and we need to get the disease under control. So we reserve it for young patients who have high cytogenetics or heavily pretreated. So now let us go on to ibrutinib data. So now that we have learned the basics of CLL, what is CLL, when do we diagnose it, what are the classical peripheral smear abnormalities, cytogenetic abnormalities, what are the criteria, when do we treat, how do we prognosticate, what are the different subsets, low risk, intermediate and high risk, and so on. So now we will go on to the data on ibrutinib. So ibrutinib presently is approved by US FDA in CLL or SLL, relapsed refractory mantle cell lymphoma, Waldenstrom's macroglobulinemia, marginal zone, and chronic GVHD after one line of treatment. Whereas in Europe and India, there is approval up to now for CLL small cell lymphoma, relapsed refractory mantle, and Waldenstrom's macroglobulinemia. So what is the mechanism of action of ibrutinib. So as the the root is there in its name, it's a proton tyrosine kinase inhibitor. If you look into the cell, we have the B cell receptor, and there are signal transduction pathways that is there in between. There are multiple signal transduction pathways that convey up to the nucleus. So the BTK being there in between. So ibrutinib plays an important role by inhibiting this BTK, where it cuts down the signal transduction between the B cell receptor and the nucleus, the NF kappa beta. So you can also see the PIK3CA also being there, the beta one. So uh, 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 this ibrutinib basically inhibits this proton tyrosine kinases, which basically interferes in the signal transduction from the B cell receptor to the nucleus. So this will result in less B cell trafficking, less chemotaxis, and less multiplication and adhesion. Therefore, we usually see that once the BTK inhibition is seen, all the cells which are there in the lymph nodes, spleen, they start coming out into the blood. What we see is a transient lymphocytosis post treatment with ibrutinib, and then we see the resolution because it interferes with adhesion, B cell trafficking, chemotaxis, and so on. So it also prevents malignant B cell proliferation. So probably this is the reason why, because of less adhesiveness, less chemotaxis, all the abnormal B cells that is there in the lymph nodes and spleen, they start coming to the peripheral blood for the initial 2 to 4 months, and then they slowly, the multiplication is taken care of, and then they slowly die off. So what is the dosage of ibrutinib? So ibrutinib at approximately the same day, the glass of water, we have to swallow it. Should not be chewed or it should not be broken, and it should be taken at a particular point of a day so that we remember and take at that particular time. If a dose is missed, it should not be taken double the subsequent day. It should be taken as early as possible. And the dose of ibrutinib is 420 milligram once orally until disease progression or unacceptable toxicity. For ibrutinib, for CLL, ibrutinib can be administered as a single agent or in combination with rituximab or obinutuzumab, or also in combination with bendamustine. I'll be showing the data further. When administering ibrutinib in combination with rituximab or obinutuzumab, we must consider administering ibrutinib prior to rituximab or obinutuzumab when given on the same day. So these are important things. It can be combined. It can be given monotherapy, combined with rituximab or obinutuzumab or even BR. And if you are giving as a combination, then give ibrutinib before these monoclonal antibodies or chemotherapies. So these are the dose modification. What is important is grade 3 non-hematological toxicities become quite important. Others like grade 3-4 neutropenia with infection or fever, grade 4 hematological toxicities, all are important. And you can see the way the dose reduction is. You can go up to 140 milligram once a day and even 70 milligram, which I will be showing. So should be cautious when we are using CYP3CA inhibitors, CYP3A inhibitors, and modify the dose accordingly. And ibrutinib is mainly hepatic metabolized. So in renal insufficiency, the dose is not that greatly modified, whereas in hepatic insufficiency, in child pug A is 140 once a day, in B it's 70, and the moment it is C, it's not advisable to use. So when you give ibrutinib for a patient, we usually start with 420 milligram once a day, and then of course at the recommended dose as per the hepatic sufficiency, hepatic reserve, and then we have to manage in the initial 6 months, which is quite important, where we monitor for side effects. We keep calling them 15 days in the initial month and then monthly, and then we can have longer follow-up dates, and then we should stay on the course and watch for disease progression. And now we have the real world evidence of the longest follow-up up to 8 years of the BTK inhibitor. So this is what I was saying about early reduction in lymphadenopathy, and this is associated with a transient peak in lymphocytosis. This is quite important. Uh, uh, More than 50% from baseline increase in the lymphocytes. This is because the adhesion is reduced, the chemotaxis, the lymphotaxis is reduced, therefore they start coming to peripheral blood. And remember, it is seen in nearly 73% of patients, and the peaks happen at 4 weeks and they usually resolve by 19 weeks. And it occurs concomitantly with reductions in lymph node size, spleen size, and frequent improvement in cytopenias. Cytopenias improve, even the lymphocytes increase, everything reduces, but the WBC count, the lymphocyte count, goes up. And lymphocytosis is a pharmacodynamic effect and should not be considered progressive disease, because for the initial 4 to 5 months you may see an increase in lymphocytosis and should not be confused with disease progression. So it shows sustained hematological improvements. You can see improvements in hemoglobin and platelet counts. And very important is this global quality of life is well improved. You can see the comparison of the Resonate 2 trial, where the quality of data showing that there is a clinically meaningful improvement in global health status, and it is sustained even beyond 3 years. So that is an excellent data, long-term data of the fatigue scores or the global scores are all better with ibrutinib when compared to chlorambucil. The disease-related symptoms like weight loss, fatigue, fever, night sweats, abdominal pain, anorexia all improve better with ibrutinib when compared to chlorambucil monotherapy. So ibrutinib has minimal renal clearance, as I was saying. There is no dose adjustment required if if the renal clearance is above 30, and hydration should be maintained, and serum creatinine levels to be monitored periodically. We must look for tumor lysis syndrome if the disease burden is high. So, because there is a transient increase in the lymphocyte count, we should be cautious about leukostasis and increase in viscosity. Therefore, hydration and cytoreduction becomes important, and bleeding related events also become important, because there is not only thrombocytopenia but also thrombasthenia. So they are inefficient platelets, therefore bleeding may be seen as a struggle. Infections, cytopenias are also common. And I was saying you that lymphocytosis is seen in substantial 70% patients, where there is 50% increase from baseline in absolute lymphocyte count. So when ibrutinib was administered in combination with BR or obinutuzumab, the lymphocytosis was infrequent. You can see 7%. Whereas if you use ibrutinib monotherapy, the transient initial lymphocytosis is nearly 70%. And it coincides with improvement in counts and resolution of lymph nodes and organomegaly. So this is the integrated safety analysis of patients with CLL in both Resonate and Resonate 2 trials. So the adverse events were primarily grade 1 and 2, and dose adjustments were infrequent. So now we have this 8-year follow-up data of ibrutinib in first line and relapsed refractory. This is the final analysis of the pivotal phase 1b part 2 trial, and these were the initial dose escalation trial that they used, phase 1b part 2 study, and they have a long-term follow-up of these patients. I will show you why this trial is important. This is an investigative assessed overall response rates, duration of response, PFS, OS, and safety. And the most frequent primary reason for treatment discontinuation was progression of disease, which was there, and adverse events in few patients. So you can see the improvement in progression-free survival in the frontline treated, and also in relapse refractory setting. You can see the median progression-free survival was not reached with first line versus 52 months in the subsequent line setting. And that's why it becomes important to expose CLL patients not in the later lines, but to expose these effective drugs as early as possible. So in the relapsed refractory patients, median PFS rendered longer with fewer prior lines of therapy. So the earlier you use, the better it is. the longer the survival. So use of ibrutinib in earlier lines of CLL has better outcomes than using them in first, second, third, or fourth line setting. So these are the chromosomal abnormalities. Very important is if I use a conventional chemotherapy or rituximab or a C20 therapy, there is a difference with the p53 mutation or with that of the IGVH mutation. Whereas if I use a BTK inhibitor, those high risk things are easily handled. So with a median follow-up of 87 months, for the first line treatment, the median overall survival was not reached, and the estimated 7-year overall survival was nearly 84%. And with the median follow-up of 82 months for the relapse refractory patients, the median overall survival was 92 months, and the estimated 7-year OS was 55%. So the median overall survival trended longer for relapse refractory patients with fewer lines of therapy before. So again, indicating that earlier the use, better the results. And these are the grade 3, 4 adverse events. So what was most notable is hypertension. And this decreased over a period of time. The initial 3 months becomes important. And as we follow them up, these side effects can be easily handled and the complications reduce. So again, stating that these adverse events, they reduce over a period of time. So what were the conclusions of this phase 1B or 2 study? With up to 8 years of follow-up, which is the longest follow-up we have for any BTK inhibitor right now. So the PFS and OS benefits of ibrutinib were minimally impacted by the complex karyotype without concurrent 17p deletion. The ibrutinib administration in earlier lines in relapse refractory resulted in improved PFS, providing evidence for earlier introduction of ibrutinib, and there were no serious adverse events, and the most frequent grade 3 were as per the previous reports, and the prolonged ibrutinib treatment was generally well tolerated with similar discontinuations due to adverse events in both first and subsequent line. So why this paper is important? This paper supports efficacy and favorable safety of single agent ibrutinib as first line and also in relapse refractory treatment in patients with CLL, and represents the longest follow-up for single agent ibrutinib or any other BTK inhibitor till date. So now we will go to the other trials. So the Resonate 2 trial, where we compare in the frontline setting ibrutinib versus chlorambucil. And then we have the Illuminate trial, ibrutinib Gazyva versus Gazyva chlorambucil. And then the Alliance trial, ibrutinib or ibrutinib rituximab versus bendamustine. And then we have the ECOG 1912, ibrutinib rituximab versus FCR. So you can see that ibrutinib has been compared head to head with all effective chemotherapy or monoclonal antibodies. You can see there is head to head comparison with the weakest partner, that is weakest molecule, that is chlorambucil. And then in Illuminate trial, there is comparison of ibrutinib Gazyva versus Gazyva chlorambucil. And then in the Alliance study, there is head-to-head comparison with PR, which is standard of care in majority of patients today. And in the ECOG 1912, there is head-to-head comparison with FCR. So basically, practically all the standard treatments of CLL have been compared head-to-head with ibrutinib. And in all the trials, ibrutinib is superior to the comparator arm. So this is the Resonate 2 study design. So the eligibility criteria was previously untreated CLL or SLL, age more than 65 years. For patients 65 to 69 years of age, comorbidity that may preclude FCR was included, and so the patient should not be eligible for FCR because we are giving chlorambucil in the comparator arm, and the deletion 17p was excluded, and the stratification factors was the ECOG performance status and the Rye stage. So ibrutinib 420 milligram, the randomization was 1:1. That is ibrutinib 420 milligram once a day, until disease progression or unacceptable toxicity in 136 patients, and chlorambucil 0.5 milligram per kg to maximize to 0.8 milligram per kg day 1 plus 15 of a 28-day cycle up to 12 cycles. And the primary endpoint is progression-free survival. And the secondary endpoint was overall survival, response rates, sustained hematologic improvement, and safety. So over half of patients remain on continuous single agent ibrutinib with up to 5.5 years of follow-up. And you can see the median duration of treatment was nearly 57 months. So more than 3 years, you can see what is important is that 79% patients were continuing on ibrutinib in this particular trial. So the study met its primary endpoint where the progression-free survival in the ibrutinib arm was statistically significant, and it is better when compared to chlorambucil. The median PFS was not met in the ibrutinib arm compared to the chlorambucil, and you can see the hazard ratio being extremely impressive. So at 5 years, 70% of ibrutinib treated patients and only 12% of chlorambucil treated patients were estimated to be progression free and alive. So 70% versus 12% at 5 years. So quite a significant number, and you can see the forest plot how whether you have deletion 11q, whether IGVH mutation is there or not, whether you have any risk factor, all the subset was benefited by ibrutinib when compared to chlorambucil. So the PFS was maintained across all baseline characteristics, and ibrutinib also improved overall survival with high prognostic risk, especially TP53 mutation, 11q deletion, or unmutated IGHV. So you can see that an impressive 5-year progression-free survival in the ibrutinib arm compared to the chlorambucil arm. So this is extremely impressive. This particular graph shows that if you use ibrutinib, whether deletion 11q is there or not, whether IGVH is mutated or not, doesn't matter. Both the subsets equally benefit. Whereas if you look into chlorambucil, the moment deletion 11 is there, it performs poorly, and the IGVH unmutated subset performs poorly. So these negative prognostic indices like deletion 11q or IGVH unmutated IGH, all these are counteracted and balanced by uh, ibrutinib. In contrast to the chemotherapies like chlorambucil or monoclonal antibodies. So then, ibrutinib OS benefit versus chlorambucil in first line CLL SLL continues in long-term follow-up also. So you can see the 5-year estimates are 83 versus 68% with a hazard ratio of 0.45, and the confidence interval is well within unit. So what are the conclusions? In the longest follow-up up to date, up to 5.5 years from a phase 3 study, the first line BTK directed therapy, single agent ibrutinib, conferred sustained PFS and OFS benefit versus chlorambucil. The median investigator assessed PFS was not reached in the ibrutinib and was 70% at 5 years. The rate of progression during ibrutinib treatment was low. There were no new safety signals. So an impressive improvement in progression-free survival with a very impressive hazard ratio, both in the good risk and also in the poor risk like deletion 11 or unmutated IGH. So now we will go on to, so we finished the comparator arm with chlorambucil, which is a weaker comparator, and now we will see Gazyva ibrutinib versus Gazyva chlorambucil. Again, treatment naive CLL SLL, serves more than 6, age more than 65 or less than 65 with at least one serves more than 6 or critical clearance less than 70 or deletion 17p or p53 mutation being present if the age was less than 65, because FCR, they should not be eligible for FCR, and the performance less than 2 or equal to 2, and measurable lymph node disease, creatinine clearance above 30, and adequate liver, renal, and hematologic function. The performance status was 0, 1 versus 2 certification, and cytogenetic 17p deletion 11q, deletion 11q with or without 17p was all included. So 1:1 randomization, 113, 116 patients in these arm, Ibrutinib 420 once a day with obinutuzumab with the classical day 1, day 2, followed by weekly for the initial, then followed by monthly regimen versus chlorambucil obinutuzumab was used. So these were the randomization arms which were there, and the progression-free survival, which was the primary endpoint, was met. It was statistically significant with a hazard ratio of 0.25, and the median PFS was not met, whereas 3-year PFS 76 was 33% statistically significant. And very importantly, IGVS mutation present or not in both the subgroups, Ibrutinib Gazyva did well, and adding Gazyva to Ibrutinib did not add much. So Ibrutinib improved PFS regardless of IGVH mutation. So what was the conclusion of the Illuminate study with the 4-year follow-up? Sustained PFS benefit was observed with first-line Ibrutinib Gazyva in patients with CLL, SLL. Importantly, similar benefit was observed in patients with high-risk features, even when the patients with deletion 17p were excluded from high-risk analysis. So cumulative rates of undetectable MRD increased over time when you could put ibrutinib in combination with Gazyva. With a low rate of molecular relapse, the adverse event profile with extended treatment in the Ibrutinib Gazyva arm was like safety results previously reported in the primary analysis of Illuminate study. And the majority of adverse events resolved or recovered with Ibrutinib dose reduction and can be successfully managed. So we just saw that even if you use Gazyva chlorambucil in the comparator arm, Ibrutinib still stands superior to Gazyva chlorambucil. And now, very practical study, Ibrutinib head-to-head comparison with bendamustine rituximab, and we also have Ibrutinib rituximab being there. So, previously untreated CLL, more than 65 years old, patients again precluding FCR. So the Rye stage, ZAP70 methylation, all were included, 17p, deletion 11q were there. So bendamustine rituximab, ibrutinib rituximab, these are the 3 arms, 1:1:1 randomization, 180 odd patients in each arm, primary endpoint PFS as all other trials, secondary endpoint OS and safety. And again here you can see that the moment ibrutinib is there, the curves are high up with a hazard ratio of 0.39. Adding rituximab did not matter much because the driver here was ibrutinib. Again, PFS was impressive with an impressive hazard ratio with 0.39. So whether you compare ibrutinib monotherapy with BR or ibrutinib rituximab with BR, so the ibrutinib arm fared better than that of the B plus R arm. So you can see that all the subgroups benefited, whereas the high risk subgroup did not benefit well with BR. So whether IGVH is muted or not, deletion 17p there or not, 11p there or not. So all subgroups benefited in the ibrutinib arm. So the conclusion is that the treatment with continuous ibrutinib, either alone or in combination with rituximab, was superior to 6 cycles of B plus R regarding PFS. The superior PFS was maintained in all the risk groups, and there was no significant difference between ibrutinib or ibrutinib rituximab with regards to PFS. With the short follow-up period, there was no significant difference among the 3 treatment groups with regard to OS. However, longer follow-up would be needed. And there's also a matter of crossover that happens. So, and then coming on to the last trial, that is ECOG 1912, where there is head-to-head comparison of the best chemotherapy regimen, FCR versus ibrutinib rituximab, head-to-head trial. So you can see previously untreated, age less than 70, because they have to be fit, they should be able to tolerate, and patients with deletion 17p were excluded in this particular trial. 2:1 randomization, ibrutinib rituximab versus FCR. You can see the way day 1 to day 3 of fludarabine. and cyclophosphamide. So even if we had FCR in place, even then this oral tablet ibrutinib in combination with rituximab fared better, and the study met its primary endpoint with a statistically superior progression-free survival with a hazard ratio of 0.39. So even with the best chemotherapy comparator FCR, ibrutinib rituximab did better than FCR. So if you look into the IGVH mutation status, as I was mentioning before, the moment IGVH is unmutated, FCR does very poor. Whereas in the IGVH mutated group, you can see that the hazard ratio is 0.44, but still the FCR is doing fairly well. So in the present day, the only indication for FCR is a young, fit patient who can tolerate FCR, who does not have high risk cytogenetic mutation, and has a IGVS mutated patient. So otherwise, FCR practically is obsolete in the present day. So the overall survival also, if you look into the hazard ratio, is 0.34. And then these are about the frontline studies where we had comparison head-to-head with all the chemotherapy or the immunotherapy arms. And now quickly revising the relapse refractory setting, the Resonate trial, ibrutinib ofatumumab, which is a novel anti-CD20. The comparison was done, and this was in the relapsed refractory setting, phase randomized trial, around 190 odd patients in each arm, baseline characteristics well matched, and again the study met its primary endpoint with a better PFS and also better overall survival. Impressive hazard ratios were there. And then the 6-year follow-up, you can see that in the Resonate study, the ibrutinib did better in terms of progression-free survival and overall survival. And then we have the Helios study. It's a 5-year follow-up of bendamustine rituximab in patients with relapsed refractory CLL. You can see the randomization, ibrutinib plus BR, where they combined ibrutinib with the B plus R regimen, and then they went on to receive ibrutinib until progression. So patients aged more than 18 years with active CLL/SLL disease meeting the IWCLL criteria, relapsed refractory disease with at least more than one line of therapy before the ECOG performance 0 to 1 and measurable lymph node disease. And they excluded 17p because B plus R doesn't work in this subset. And the primary endpoint is the investigator assessed PFS, secondary was OS response rate and PFS2. And even here in this study, when you could see, the moment you put ibrutinib with B plus R, it is superior to B plus R alone. So median investigator assessed PFS was better in ibrutinib plus B plus R in the relapsed refractory setting compared to B plus R alone. So 14.3 months was the median, and it was 65.1 months, which was statistically significant, and the hazard ratio being 0.2. So the PFS2 was also longer in the ibrutinib plus B plus R arm. For patients who had received a subsequent therapy, the time to from start of the subsequent therapy to progressive disease or death was also longer with the ibrutinib arm and compared to the B plus R arm. So you can see the overall survival benefit also being there at 5 years, 75 versus 60%. So why is this paper important? This is the paper that supports the long-term survival benefit of ibrutinib in combination with B plus R in patients with CLL/SLL. Safety profiles were consistent with the previous ibrutinib trials. So now coming on to the concluding parts, the NCCN guidelines support ibrutinib use for everyone now. So previously in 2018, ibrutinib was reserved for frail elderly patients. Ibrutinib was to be used. We also had options of B plus R, chloramucil, Gazyva, and now in young fit patients there was FCR, and it was reserved only for TP53 mutated patients. But now, after all these trials, the 6 trials I showed in the frontline treatment, ibrutinib can be placed in all the subsets, irrespective of age, comorbidities, whether elderly or not, irrespective of the risk, high risk, low risk, cytogenetics, TP53 present or not, IGVH mutant or not, doesn't matter. all subsets benefit well with ibrutinib, and it can be used with monotherapy. And adding ibrutinib with rituximab did not add much. So ibrutinib monotherapy is sufficient enough, and it is superior to any other comparator in the front line. So the first line treatment of CLL must be based on disease status, presence of 17p, IgVH mutation status, patient's age, performance status, comorbidities, and toxicity profile. So ibrutinib is the preferred first-line treatment choice for all patients, including high-risk subsets. So whatever the risk group, ibrutinib does well. So in the present day, if a young patient who has IgVH mutation positive, only in that subset, without having T53, only in that subset we can use FCR. Otherwise, if a patient has the affordability and has the prospect, ibrutinib becomes standard of care for all patients irrespective of risk. So this is the Esmo Cll guidelines. IgVH unmutated, fit patient, ibrutinib. You can see ibrutinib being there in each and every box, irrespective of any type of mutation. So we have other options popping up: venetoclax, obinutuzumab in unfit patients, and then in fit patient FCR, and then we have idelalisib being there in patients who have P53 mutation, venetoclax plus obinutuzumab or venetoclax monotherapy popping up there. So symptomatic relapse CLL, T53 deletion is there or not, because we must be testing P53 at each progression. So the moment it is high risk, then ibrutinib or acalabrutinib comes, venetoclax, rituximab, venetoclax alone, idelalisib plus rituximab, or allotransplant to the patient is fit. If the short remission duration is there, again the same all BTK and venetoclax BCL2 inhibitors come in place. And if you have a long, more than 3 years progression-free interval, then you may use the same regimen which you used before, or the same molecules can be again used here. So we have these BTK inhibitors that can be used in any risk, any line, any subset. They are superior to any standard cytotoxic chemotherapy or CD20 antibodies. So what are the take-home messages? So these are the long-term data of ibrutinib in first-line CLL. The Resonate 2 trial showed 60 months follow-up with a 5-year PFS of 70% and the overall survival 5 years of 83%. The ECOG 1912 where head-to-head comparison with the FCR with 48 months follow-up, you have a 3-year PFS of nearly 90%, overall survival of nearly 100% in head-to-head comparison with FCR. And then the Illuminate trial, again, you are having 3-year PFS about 75%, and Alliance study, again, more than 85% PFS, and the overall survival crossing 90%. In the phase 1B or 2 has the longest follow-up, up to 8 years, and we saw the data. So the overall survival benefit of ibrutinib regimen shown versus FCR, we have 7 out of 10 first-line CLL patients progression-free and alive at 5 years, consistent outcomes with ibrutinib irrespective of subgroup, and the consistent safety profile shown in up to 8-year follow-up data in the phase 1b2 study. So to summarize, ibrutinib, a first-in-class inhibitor of BTK, is approved in India for treatment of adult patients with CLL. It allows for once daily dosing and treatment without chemotherapy. A superior PFS of first-line ibrutinib-based therapy shown in 4 phase 3 randomized clinical trials versus standard of care chemoimmunotherapy, whether it is FCR, BR, or Gazyva chlorambucil or chlorambucil alone, and a superior overall survival versus FCR and chlorambucil. So long-term safety is established. The earlier the use of ibrutinib, better the outcomes which we saw in those. So with these extensive data, so I would thank everyone for their patient listening, and I would thank Johnson and the organizers for providing the opportunity. So thank you. So back to you, Dr. Dev.